So we move on to the next session, the last session of the conference. What is the best management for acute hypoxemic respiratory failure in non-intubated patients? High flow oxygen, CPAP, NIV, awake prone. So to chair the session, may I request Dr. Manav Manchanda to step on stage. Dr. Manav is the Director, Department of Respiratory Critical Care and Sleep Medicine. He has 21 years of experience and also a DNB teacher. He's member of various Indian and international scientific bodies. Welcome, sir. To co-chair the session, may I request Dr. Ajay Gupta, who's the fellow intensive care, who's a fellow from Intensive Care Australia and Director Critical Care Max Shalimar Bagh. Welcome, sir.
Not just for onco but for general critical care as well. And I think after COVID we have learned a lot of things about the management of hypoxic respiratory failure. Awake prone is a term which has come in post-COVID because a lot of COVID patients found a lot of benefit from it. Use of NIV, use of high flow nasal cannula after the COVID pandemic has now picked up quite a lot. And I think speakers introduction can throw more light on this topic. And Dr. Vimal, I think, tell us to
the most difficult lectures are the first lecture for lecture. In special interest in respiratory critical care. Probably he'll not remember me, but we were his students and were taught by him also a couple of years ago. Okay, thank you.
Thank you. Not only it's difficult to give the last lecture, I think it's more difficult to listen to the last speaker. So thank you all of you who are still around to listen to this talk. So this is something we face in critical care every day. Hypoxemic patient, not hypercarbic, and non-intubated. So various options that we have to deal with. One is of course conventional oxygen therapy, and we know the various modalities which are available to us. FiO2 that we can deliver is limited to an extent, humidification is limited, and there is no ventilatory support. Then NIV is something we have been using since mid-90s, and it includes both CPAP and BiPAP, and we can use the conventional oronasal mask, although occasionally we do use even the nasal mask, or helmet. The advantage is better humidification, FiO2 delivery can be much higher, and the interface intolerance is a problem, especially with the oronasal mask. The high tidal volumes which can happen because patients may are spontaneously breathing and they are very breathless, they can sometimes make a lot of respiratory inspiratory effort, and such a high tidal volume may actually cause patient-induced lung injury, and of course barotrauma. And biggest problem is you put a mask on, the numbers look fairly all right on the screen, and so the intubation gets delayed. Then HFNC, something available more recently to us, and thanks to the COVID, our units everywhere purchased these units, the HFNCs, and we started using them more and more. So high flows and high FiO2s is a big advantage in these. The interface is very small and simple to put, doesn't require much of an expertise. Humidification is very good, and there's better tolerance of the interface. And again, there is a problem that we may actually cause delay in intubation and possibly harm the patient. And awake prone position was something which we were never using before COVID. We were using prone in ventilated patient, but awake prone was a new thing. But it came in vogue, and it could be used with any of the above modalities. So, for the intensivists here, a quick look at various technical and clinical characteristics. I just made up this table. See, interface we just mentioned. HFNC can also be delivered via tracheostomy adapter. The NIVs give positive pressure, which could be biphasic or a single pressure in a case of CPAP. In case of HFNC, the flow is regulated and it can potentially generate between 2 to 4 centimeters water of CPAP depending on whether the patient has a mouth closed or mouth open. The flow rates are variable. For HFNC, the flow rate is constant because you actually setting the flow rate. The airway pressures are constant or biphasic in NIV, and they are variable and depends on the patient effort and the compliance of the thoracic system in case of HFNC. Humidification is decent, provided often we use humidifiers in line with the circuit, and we get 5 to 30 milligram per liter of humidification, whereas with HFNC is even better, is almost saturated 44 milligrams per liter. The complications are small. The pressure source, the air leakage, the eye irritations are common in ICUs. We deal with it every day. Similarly, you can get nasal irritations, little bit of epistaxis, nasal obstruction, and certain amount of feeling of expiratory resistance because of the big thing sitting in the nose with HFNC. End expiratory lung volumes would be increased in NIVs and to an extent even in HFNCs. The work of the PF ratios improve in NIV patients and including CPAP and BiPAP, but actually it doesn't improve in HFNC. What improves is saturation or PaO2 because of higher FiO2. The work of breathing can be decreased in both, and in case of HFNC similar to CPAP. In case of bilevel, it is proportionate to the pressure support that we are delivering to the patient. The need for intubation can be high in case of NIV, and as high as 50% in non-ARDS patients and perhaps even more in ARDS patients in some of the studies. Of course, these figures vary from study to study, and it's similar in HFNCs. Mortality in Florali trial was 28% for NIV and 12% for HFNC. So that's a brief overview of these two common modalities. How does HFNC work? We probably know it already if we are using it. So there is certain amount of humidification patient which improves the comfort level and possibly decreases microatelectasis. The high flows help both in the inspiration and expiration, improves PaO2, and by washing out the dead space PaCO2, and it tends to decrease the work of breathing because the oxygen levels are better, the respiratory rates tend to fall down, and of course we are washing out the CO2, and it tends to match the high respiratory demand of a patient. So we look at various modalities and the studies out there. So there's a meta-analysis of 6 trials of hypoxemic respiratory failure. They didn't include cardiogenic pulmonary edema, acute hypercapnic failure, or HFNO used in post-extubation, and compared these studies compared with conventional oxygen therapy. More than 2,700 patients, and combined mortality of 20% by day 30. The significant difference compared to conventional oxygen therapy, where the mortality was less in case of NIV, in case of HFNC. The evidence for difference in treatment effect for immunocompromised, including COVID-19, was not there. The pooled rate of intubation was 43%. The meta-analysis identified a significant beneficial effect of HFNO compared to oxygen therapy in preventing intubation, but no difference in the COVID sub-arm. So no difference in mortality overall. What we don't know about HFNC is the long-term functional outcomes. There is some data out there, not much though. How long to give a trial, when is late and when is good enough to continue, whether to use ROX or other indices to determine failure, I'm sure you know what ROX is, and this index gets more specific and better at predicting longer the duration. So a ROX score less than 3.85 at 12 hours means there's higher chances of intubation. So whether higher mortality in failed cases is due to delayed intubation or simply those patients who are more severe is also a question. Obviously, more severe patients won't do better no matter which modality you're using. Then we look at HFNC versus NIV, a meta-analysis of 4 RCTs, 2 of them were COVID-19 patients. Meta-analysis did not identify significant difference between the two for either mortality or intubation. However, studies did show completely different kind of data for COVID-19. In one of the study, the HFNO by Greco, HFNO showed significant increase in rate of intubation at day 28 compared to NIV. In Nair et al. On the other hand, showed that there was a 19% absolute risk reduction in HFNO as far as the intubation rates were. So two opposite completely opposite data. So now comparison of NIV to and CPAP to versus conventional oxygen therapy. 10 RCTs, 6 had NIVs versus COT and 4 were CPAPs without versus COT. Analysis including all studies showed protective in terms of intubation rate and mortality. However, analysis with limited studies, which was I think 5 studies with the less risk of bias, they didn't find this effect. The COVID-19 patients reported a lower intubation rate with CPAP as compared to conventional oxygen therapy. Now, helmet NIV versus HFNC. This is a trial published in 21, 110 patients who were given helmet NIV for at least 48 hours, half of them followed by HFNC, and the other half of the patients received only HFNC. So intubation was significantly lower in the helmet group, 30% versus 51% in the HFNC group, and the days free of invasive mechanical ventilation was significantly higher in the helmet group. In-hospital mortality was no different. Then another one small study, single center study, looked at helmet versus face mask NIV, and there was a 22.3% mortality reduction with helmet. With greater prevalence of ICU acquired weakness was there in the other arm, which was face mask NIV, and less functional independence. 1 year follow-up data was also looked at. Mortality was higher in the face mask NIV group, and at 1 year, patients in the helmet group were more likely to be functionally independent and had more institution-free days as compared to the other arm of the study. Now, there are 2 studies of helmet in COVID-19. This is a study in 2022 from JIMS, Greater Noida. They looked at compared the effect of non-invasive ventilation delivered by helmet versus face mask NIV in COVID-19 patients and a randomized control trial. It's amazing that they managed to do an RCT in a scenario of COVID, which was a very difficult scenario, but congratulations to the team. Around 10% of the patients in the helmet mask group were intubated, while 43% in the face mask group got intubated. And this was highly significant difference. The use of helmet mask enhanced oxygenation, higher patient satisfaction was there, lower risk of complication, and shorter NIV and NIV requirement and ICU stay. A very strong study suggesting helmet mask in such patients is an advantage. This is a study which we published in 2021. This is from my unit. We looked at data from the first 30 patients of COVID-19 which we put on helmet mask, And we found that 70% of the patients managed on NIV and they came out, the rest 30% needed intubation. And there was higher mortality in those 30%. What we found is that the PF ratio of cutoff of 161 was a good cutoff to know when which patients will do better off on a helmet. The other thing which helped is the delta change. So a PF ratio improvement at 2 hours was apparent in those who were getting better versus those who did not do well. However, this was not significant. This difference between the ones who did well on the helmet mask versus ones who did not or needed intubation was significantly different at 24 hours. So probably a trial of 24 hours is good enough to tell us which patient is going to do well, which patient we should probably take up for intubation. Of course, it's a small study, just 30 patients. Awake proning, as I mentioned, was something new for most of us, and we learned about this and started using in COVID-19. The analysis of APP versus control was done in 3 publications. One of them was a meta-analysis of 6 trials. Hence, this data is actually coming from 8 trials. One of the studies of these 8 trials was from Mexico and showed significantly lower risk of intubation. If we looked at the data from remaining 7 studies, there was no decrease in intubation rates. But when they are added up, all the studies are added up, then it does show that there is a significant risk reduction. So probably the entire data was skewed by the Mexican study. Now, helmet NIV has also been used along with the prone positioning. This study is not mine, but this picture is from my unit. This patient was on a helmet and we proned this patient, but we were in no state to capture this data and write a publication. There were more on our mind at that point of time. But this particular study published last year, 11 COVID-19 ARDS patients failing 1 hour of supine helmet CPAP was switched to helmet CPAP with proning. And they found that PF ratio improved from that before proning. There was a significant increase in SpO2 and decrease in respiratory rate. No difference was observed in the PaCO2 or pH. At day 28, 2 patients had died after ICU admission. One was discharged to the main ward after ICU admission. The 8 patients were discharged home. So, small study, but interesting data. And this is something which is still in the works, combined use of HFNC and NIV. So the same patient would be on NIV some period of the time of the day and on HFNC on the remaining part. So for instance, patient at night could be on NIV and during daytime could be on HFNC, or what we often do is the patient is on NIV, we remove the NIV and put on HFNC so patient can have oral hygiene done, to have drink of water, to eat, and then they go back on NIV. Now this is work in progress. So the study on the left hand side is actually just a study protocol. It's not a study which is still being done, not published. The one at the bottom right of the screen is a study which has been published but also retracted. So nice study, for some reason it's been retracted. And the one on right hand top is also study in progress, is not yet happened. Now these are in hypercapnic respiratory failure, but people are using, even me, we are using these even in hypoxemic respiratory failure in the unit. HFNC has an advantage of being more comfortable. NIV has an advantage of decreasing the work of breathing better. But of course, we need data before we adapt this. So how do we go about managing patients with acute hypoxemic respiratory failure? This is a ready flow chart I picked up from somewhere. I forget what is the source. So they looked at using conventional oxygen, 5 liters, up to 5 liters per minute, target SpO2 more than 94 and respiratory rate less than 28. So if the target was not achieved, then they switched either to CPAP with helmet or alternatively NIV with face mask, and they followed that. What do I, how do I handle it? I don't have a standard guideline available to me, so I use a little bit of common sense. So if we get a acute hypoxemic respiratory failure, and we obviously look at the cause and treat the cause. So if there's pneumonia, we treat the pneumonia. If there is congestive failure, we treat that, etc. So assuming it's non-cardiogenic pulmonary edema and it's the rest of the group, then start with conventional oxygen therapy. We don't achieve adequate oxygenation, and two, the patient looks tired, is kind of quite tachypneic, still working hard on breathing. We look at an ABG to look at hypercapnia. If there is hypercapnia, put on an NIV. If there is no hypercapnia, we put on HFNC or CPAP. We don't use helmet CPAP. Actually, that requires a flow generator along with a helmet mask. What we have been using in our unit has been bi-level through the ventilator and a helmet. But it's usable. If we have a CPAP and a helmet, a flow generator to do that, we can potentially do that. But what we use is CPAP using a mask. If the workup breathing is still high, switch to a bi-level and tweak the pressure support till you can decrease the workup breathing to an extent. And of course, sometimes we switch between HFNC and NIV. That can help. Awake proning is a modality which can be potentially tried, and if all fails, mechanical ventilation. Thank you. That's my last slide.
How long you wait before intubating the patient with trial and are you assess the patient condition? Acute hypoxia
without hypercapnia. So I don't think there is any formula to decide that. The only way to decide when to intubate is clinical.
You have written in algorithm you wait for 120 minutes.
That's the one on the left side.
Yeah.
That's not my algorithm. I just picked it up from the net.
You
So we use good old clinical sense. Look at the patient. Does the patient look uncomfortable? It's very tachyc. You know, all of us know the symptoms. He's using accessory muscles. He's looking visibly tired, looking distressed. You ask the patient, they're conscious patient, are you better? Sometimes he's looking very tachypneic. You ask, he says, I'm better. So then you know you can wait for some more time. The other thing is do ABGs. So if you find that CO2s are started climbing, then you know whatever he is saying, he's actually getting tired. So these are good ways of.
the patient is feeling subjectively very better and but saturation is still down. Same but not improving. The patient is feeling comfortable.
See, oxygenation, it will improve not only on your vent because of the modality that you're using, HFNC or NIV or conventional oxygen. It will depend also on the underlying condition. If somebody's got a huge bilateral pneumonia, so as long as your oxygen saturation is 90 plus and patient is fairly comfortable, is not tiring, you just continue and keep watching. As the patient's clinical underlying condition will start improving, the patient will get better. If, however, despite obviously antibiotics are not going to do a miracle in 6 hours, it will take some time before the patient starts improving. But you find that patient is getting tired and all that, then you step in and intubate. The problem is this requires clinical judgment and somebody watching the patient. So you put a tube, you can forget. You go back, put a tube, put on the center the sedation, and go and have your coffee. Whenever we are not intubating the patient, it actually needs us to keep a close watch on the patient. So that's the challenge. And we know we are not working in ideal setups, any of us, with 1:1 nursing and all that stuff. So that's a challenge. But all the same, you put a tube, you also put in a lot of risk. We do this all the time, put a tube, but when you put a tube, you put a whole load of additional risk on the patient.
Any other questions? Okay.
One question from me. Any apparent reason why the helmet is working better than the face mask in most of the patients of acute respiratory failure?
I think most important is they can continue forever without it needing to be detached. The face mask comes off. It has to be off to feed the patient, to give some water. The helmet, on the contrary, you have that helmet, there is a jam jar kind of attachment on the side. You can open it and give the patient liquids easily. Theoretically even feed, but yeah, mostly we were using liquids with a straw. They can get medications in and then communicate. So it goes on much longer. So yeah, so that could be the reason why it's much better, and it's obviously much better tolerated. The initial fear of claustrophobia, what is this you're putting, so you need to spend a little time. Somebody who's hypoxic and you're going to put something, the whole head is going to go in. So you needed a little bit of time, but it's not difficult. We had done one helmet, literally one helmet case before we started using in our unit in the COVID, and which we used in an inappropriate patient. It was a palliative patient. Patient was going to die, and the relatives had said very clearly, no, do not intubate. So we said, we have this, do you mind if we use? It might give him some relief. And we put the helmet, he actually felt much better. So till he survived, I think, 2 days. But the learning that the unit had, the nurses and this thing, was enough for us to start using in COVID with all the stuff we were wearing. Yeah. But if you spend that 10 minutes explaining to the guy, and you needed at least 2 nurses to help you to put that helmet. Thereafter, a little bit of counseling. I think hardly any patient, maybe barring 1 or 2, or maybe 1 patient who actually had to be taken off because couldn't tolerate. Most of them, you took it off because you wanted to tube the patient. And this scenario could be changed if you use face mask and HFNC. So when you take off the face mask, put an HFNC, let him feed. So the problem with the so-called delay in intubation, etc., is probably because we take it off, and whatever good effect of face mask, BiPAP or CPAP is lost during that time.
When just 2 comments, I think we are focusing much more on the modality, but we are not focusing on the individuals also. So it's not just that HFNC is good for this sort of patients, and we are talking about that NIV is good for this type of patients. When we are talking about HFNC, I think the whole scenario changed when the COVID was introduced, and when you are saying that the patient is having a saturation of 93, 94, and the patient is sitting happily with you, then you think twice before intubating somebody that do you need to really intubate. However, the situation might be like what we had yesterday in our units also. The patient saturation is hovering at 85, 86, the X-ray is bad. We did 2 times COVID came negative. We did H1N1, it came negative. Then we did a biofire, it came eventually influenza positive. Now this scenario of the patient hanging in between, whether you need to intubate or not to intubate, is one question. But I think everybody would agree that I can be talking about HFNC, I can be talking about intubation, I can be talking about NIV. At least in COVID, nothing was better. So it is all our individual experience, what we talked about. And in an individual patient like this might be helpful. So we have jumped from NIV to HFNC mostly because of the comfort to the patient. I think helmets offer a much more comfort to the patient. HFNC offers much more comfort to the patient. But would they talk about a mortality benefit from either of these mechanisms with respect to NIV is, I think, a big question, especially with the COVID scenario. And otherwise, uh, I think everything would be whatever is suitable for one individual may not be suitable for the second individual given the same scenario of a respiratory failure. And second, I think we are missing just to end from this conference that we are, at least here we are talking about oncology patients. And I think in oncology patients, use of HFNC or NIV and not going on to an invasive ventilatory support. I think that is one of the fundamentals what we look at. So patient comfort, trying not to intubate, because moment you intubate, I think the patient will ultimately die. So I think in that scenario, in oncology patients, I think when you're talking about end of life care, when you're talking about palliative care, or you're talking about immunocompromised patients who are having superimposed infections, in those cases, I think NIV is a better option or a very good option rather than going on to an intubation for that patient. So I think that is a scenario what specifically talks about when we are talking about. And NIV, when I'm talking, it's also used in hypoxic respiratory failure, it's also used in hypercapnic failure. But there are a little bit doubt about whether HFNC would be an ideal agent when I'm talking about a severe hypoxic respiratory failure, or even when I'm talking about a congestive heart failure or left ventricular failure. So NIV has its own place. I think much more emphasis was given on HFNC in especially the COVID area, COVID time. But at the end of the day, I don't think anything changed the mortality, and we are still looking for what really helped the patient apart from steroids. I think nothing helped the patients in COVID, and that's the only thing. So it becomes a bit difficult for us to say that this is standard best, that this is for all patients. Probably we'll have to individualize and see what the primary cause of these conditions are.
A small caveat to HFNC I'd like to add. We've all gone through an oxygen crisis during the COVID times. So that small thing was there. When you use HFNC, you use a very high flow of oxygen. In those cases, NIV would be better. That's another aspect, which we've overlooked. Because Delhi, we had an unprecedented oxygen crisis. We didn't know 3 hours later whether we'd have oxygen in the hospital at all or not. It was that bad.
Well, I think when I go to the oxygen availability in times of COVID, that is probably a totally different aspect when I'm talking about, because if I was using, say, HFNC, and I thought that this was
such a lot of it.
Yeah, but what I'm saying
you
is
have
that
to do
if
some
I thought
triage
that
if
HFNC
oxygen
is a good
was
modality,
such a
then
scarce
probably
modality.
I couldn't have been talking about that the oxygen supply is a bit low, so I'll not use that. So I mean that is individual. I mean that is a situation which was not considered when we are talking about HFNC or NIV for that matter. That was an unprecedented situation, and how we dealt with that was probably a bit difficult. A different institution might have, but I think that was probably not what we are talking about.
Hopefully we'll see this. Yeah, we'll see this another 100 years later. Hopefully, it's the same scenario. And not only we were running out of oxygen, we were running out of ventilators and running out of NIVs.
Oxygen,
everything.
In our institute, we bought 5 HFNCs at the end of COVID when everything was gone. And NIVs, you don't have NIVs, okay, you get HFNC. So I think controlled trials in that sense was a bit of a difficult scenario when we are looking at it. Whatever you could get, you get. In my ICU, 20 ventilators were getting, and 1 or 2 only were ventilated. All were NIV. Everything was finished. So oxygen concentration as such 100%, most of the patients were on 90-80%, and I mean
the flow basically.
Yeah, but that was not predictable in that sense that I could say that because my flow of oxygen is less, I will not use HFNC. In my institution, there were not many HFNCs anyway. So that was not thought about as in those terms. And when you're talking about, you were talking about mechanism. And in the end, in COVID, nobody talked about that NIVs are giving such amount of
Aerosol.
aerosol production. So we
Well,
use whatever.
actually, that's one of the reasons I went for helmets. Because there's a study which showed that the dispersal of aerosol was the least when you use a helmet with a tight collar. So talking of the various modalities, there's another way of looking at it is initially we had oxygen and we had ventilation. These were the two ends. Then came NIV, something in between. So you could use an NIV instead of banging a tube in. Perhaps we got something in between now. So you have a oxygen conventional and an HFNC and then an NIV and then a mechanical ventilator. That's another way of looking at it. And people don't die and they don't survive because of modality of oxygenation or modality of support that we give, die from their disease. Lastly, not only there is a risk of delayed intubation, too early an intubation also is a risk factor, which we never talk about. Enough.
Thank you, sir.
Thank you.
Thank you so much, Dr. Mrinal. May I now request chairpersons to kindly felicitate Dr. Mrinal. Requesting Dr. Shagun to felicitate Dr. Ajay Gupta. Dr. Praveen Kaur to kindly felicitate Dr. Manav Manchanda, please. So, as we come to the end of the conference today, on behalf of Rajiv Gandhi Cancer Institute and Director Operations and Medical Superintendent, Dr. Pinky, I would like to deliver the vote of thanks, please. So, I would go verbatim. Respected seniors and dear colleagues, ladies and gentlemen, good evening to all of you. On behalf of Rajiv Gandhi Cancer Institute, it's my privilege to deliver the vote of thanks for today's event. First of all, would like to thank our seniors, our CEO sir, our medical directors, Dr. Rawal sir, Dr. Gauri ma'am, Dr. Devan sir, Dr. Doval sir, Dr. Chawla sir, for motivating us to go ahead with this program and supporting us throughout. Our special thanks to Dr. Saurabh Kumar Das and Dr. Praveen Kaur for conceptualizing the idea and executing it. Many congratulations to both of you for organizing this first annual conference of Onco-Critical Care Society 2023. And also for the extra efforts taken in bringing out the official journal of Onco-Critical Care Society. A big round of applause for them. For putting up a well-curated scientific program with very relevant topics of great interest. Sincere thanks to all the faculty members, chairpersons, panelists and moderators for coming on board for this event. We are very grateful to you all. We thank all our distinguished delegates and guests for their presence here today. Thanks for taking our time from your busy schedules to be here. We would also like to thank all RGCI consultants and staff members for their participation and presence. My special thanks to all the HODs of in-house departments and teams for supporting us for organizing this, namely our marketing team, IT, purchase, human resource, finance, maintenance, F&B, housekeeping and security departments. It would have not been possible to organize this event without your contribution. Last but not the least, I would like to thank the operations team, quality academics team for their involvement and contribution in doing this. Special thanks, as it's quoted for myself, Miss Anju, Miss Reena, Miss Nilima, Miss Jyoti, Miss Pinky Bohara, and the team on the registration desk, Miss Parul and Miss Vishali, for their immense help in putting this event together. And in the end, I would like to thank the Almighty God for His divine blessings on all of us. We hope that this small effort of Oncology Critical Care Society goes a long way in improving clinical care for the cancer patients. Thanks once again and a very good evening to all of you. Thank you.
So, special thanks to Dr. Anubha, and I would like to thank Dr. Divya. Please come on the stage. So, I would like to call team MICU. Please come on stage for a photograph, and all of you can accompany us, please. Can join us. Now it is, Come, Dr. Divya. हम कर लें.
All dignitaries may please join for the photograph. All of you, please. Dr. Pankaj, Dr. Rohit, Dr. Manav, Dr. Ajay, Pinky, Parul, Reena, Jyoti, Anju, Nilima, please come on stage, all of you. IT team, Rahul, can you please come over? Pradeep,
Dr. Bridgemont, please.